This is the Emergency Medical Minute. The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses or simply click on the link in our show notes and create an account.
In early March, before the effects of COVID-19 swept the nation, the Emergency Medical Minute collaborated with CarePoint Health to host a Brewcast on pediatric emergencies. Here is Dr. Parisa Jamshidi presenting on common respiratory conditions in pediatric patients.
Hi, my name is Parisa Jamshidi. I know some of you. I'm one of the pediatric ER physicians. I'm going to talk about some of the respiratory illnesses that's common right now. And one of the most common right now is bronchiolitis. So bronchiolitis is a clinical syndrome of a respiratory distress that usually happens in children less than 2 years of age and is characterized by upper respiratory symptoms. They start with rhinorrhea and then it advances down to the lower bronchioles and makes inflammation and infection, and which results in wheezing and crackles. So bronchiolitis usually occurs with the typical, it's a primary infection, but it can be a reinfection. And very, very rarely, if you have it in the older children, can be mycoplasma pneumonia. It's the same with Croup, by the way. So forget about it. We do not give antibiotic to any of those. In young children, the clinical syndrome of bronchiolitis may overlap the viral recurrence with the reactive airway disease. And this is why in the treatment, I'm going to talk about that. So severity, you want to see persistently increased respiratory effort. You're going to see a tachypnea, nasal flaring, intercostal, subcostal, supraesternal retraction, accessory muscle use and grunting, and you repeat them every 15 minutes to see how the baby is doing. Hypoxemia, this is for the sea level, 95%. You know that in Colorado, we are 90 to 91%, less than that. Apnea, especially in a newborn, they will develop apnea. My theory is they are laying down and the nasal, that especially RSV, that the runny nose is so bad, it's like a faucet. When they are laying down, it goes in the back of their throat. They cannot clean it and they go apneic. And acute respiratory failure, of course. Who do you hospitalize? If they look toxic, they look horrible, they have a poor feeding, lethargy, or dehydration. If they are moderate to severe respiratory distress, if they have apnea, or they are hypoxemia with or without hypercapnia, we never check their hypercapnia. Yes, we never check their blood gas. So hypoxia is enough for us. Parents that who are unable to take care of them at home. If you have somebody that's too far, if they don't have a car, they don't understand what are you saying, it's safer to stay in hospital. So what do you do for the treatment? That was the one. You can try one time the bronchodilator. And why? Because they can be the first-time wheezer with the reactive airway disease. That's a trial. The difference between asthma and bronchiolitis is the pathogenesis. So in asthma, there is a bronchoconstriction. So you will have a bronchodilator and it will respond. In bronchiolitis, it's the inflammation with the virus. So the virus is the one that's doing the damage. It's not a bronchoconstriction, so they would not respond if they don't have reactive airway disease. It's the same with glucocorticoid. So I did say that nebulized hypertonic saline we are not recommending to use in the emergency department, but it's very mainly used for the inpatient. It's the same thing. It's osmotic. It will suck up the inflammation. Glucocorticoids, as I mentioned, the pathogenesis is different than asthma, so it doesn't work. We don't recommend at all, unless if you think that they are asthma. Yes, if they respond, you can try it. Any question for bronchiolitis? Yes, sir. Usually no. You can. It was in the thing too. If you think that there is a Croup component, you can use it. It can be together. Remember, they can have a Croup and bronchiolitis together. Yes, the virus coming from the nose can get your larynx and go to your bronchioles.
So we had this in our section meeting, but it send out kids who look well but have mild hypoxemia, like 190s, high 80s. found this practice for variation where if it was at his home and they looked good, it was keeping in the hospital.
So it's the same thing with us. We usually keep them, especially the age. For me, the age is the most important part. If you have a little one, less than 6 months old, that's hypoxic, I do recommend very highly to keep in a hospital. They are already hypoxic, and the day of the occurrence is another thing. If you have a day one that's hypoxic, it's going to get worse. It gets worse before it gets better. It's 3-4 days of the disease will be worse at third or fourth night, always. So if you have a day one that's iffy, believe me, day 4, they're going to get admitted. So you better keep them in a hospital. Yes, sir. Yes, we do have a protocol for that. It's more than 6 months of age. They should not live more than 8,000 higher, and you're going to watch them for at least, according to children's that they come up, it was 8 hours, and they are really watching for 9 hours. Let me tell you, I saw 2 of their children, and you watch them, and they should not have more than 0.5 liter requirement of oxygen. So yes, you can. My other problem is if you have a toddlers that are very hypoxic, it's not during they sleep, it's all through, you're not going to keep that oxygen. They're going to rip it off. So you better keep them in a hospital at least for a day or 2. Okay. I pass to Croup. So Croup is a respiratory illness that comes with a stridor, barky cough, and hoarse voice. These symptoms result from the inflammation in the larynx and subglottic. This is what I said. It comes from the up and it's over this one. So diagnosis of Croup is clinical. So based on the presence of barky cough and stridor, especially during the common viruses, and neither radiograph or lab is necessary. You do a radiograph to rule out other differential diagnoses. So you gave racemic epi, they didn't get better. You think of something else. Yes, so you can do an X-ray for foreign body epiglottitis, laryngeal web, or blah, blah, blah. Everything else. So how do you treat the Croup? This is a mild Croup. We see a lot of them in emergency room. They usually should go to their primary doctor, but they end up in the ER too. So one of the first one is a single dose of dexamethasone. There's a debate about how much to give. Is 0.15 to 0.6 milligram per kg because it's one dose. Usually in our ER, we do use 0.6 milligram. I do round it according to don't give a funny numbers. 6.2 is funny, 6 milligram. Our vials, I don't know what is in your hospital. We have a 10 milligram in milliliter at Skyridge, and we have 4 in a milliliter at Rocky Mountain. So I go with that. So I don't want to waste the vial. And the maximum dose is 16 milligram. So for the mild one, you don't need to do with the racemic epi. Typically, you don't give a racemic epi. Sometimes I do if it's in the middle of night and, I can't send them home. So I give them one because I'm going to watch them anyway. If they are very excited, if they are having a stridor. I didn't talk about it. I'm just going to talk a little bit. If you have a subglottic inflammation comes and makes a fixed obstruction in the cartilaginous, the cricoid cartilage is fixed. So the swelling will make a fixed obstruction. And you have a stridor at rest. The second one is when you have children that are crying, irritable, agitated, there would be a turbulence and it will make an obstruction as well. This is why you keep them quiet. This is why you see them when they are crying, it's more of the stridor. Children with Croup that tolerating fluids, have not received nebulizer therapy, can be sent home with the follow-up. It can be by the phone and has been arranged, and you will give them an indication when to come back. If they have a severe or moderate Croup, number one, you approach them cautiously. As I explained to you that if they are excited, it's going to get worse. So usually we ask them to be kept on the mother's lap and we give them a nebulizer epi as quickly as possible. And you should watch them very carefully because they may need some bag and mask or intubation. It's again, dexamethasone is 0.6 milligram per kg, maximum 16 milligram as soon as they come. If they don't take it, it's so hectic, you can always use a budesonide. We never do. I think that we always give dexamethasone. Dexamethasone takes at least 1 hour to work. So it's 1 to 2 hours. This is why you get time with racemic epi. So racemic epi takes within a minute, 5 to 10 minutes, it's effective. The maximum is half an hour. So within half an hour, you have the effectiveness. It lasts up to 2 hours. This is why that minimum you watch them for 2 hours. So I wrote it down for you. Racemic epi, the dose is 0.05 and the maximum is 0.5. If you don't have it, you can always use the regular epinephrine 1 in 1,000, and that's the dose is 0.5 milliliter per kg, and the maximum is 5 milliliter. And besides that, you continue with the supportive treatment, a humidified air or oxygen, antipyretic, and encouraged for fluid intake. One of the things that I did include that one, I think it's a complication of a croup, and we saw it a lot this year, especially if your croup happened with influenza. Even though that they are saying it's the less, the croup happens, number one, with para-influenza 1 and 3 is the most common reason. The 2 is more significant, and influenza is less. Actually, there is a coronavirus there that it was found out in 2004, and this is not the same as COVID-19. It's much milder. And RSV can do it, rhinovirus, we had a lot of rhinovirus with the croup. So any respiratory virus that you can think can do a croup. Adenovirus would be a one with very, high fever and everything. So influenza is one of your worst one. And we did see so many, and we are giving them a dexamethasone, remember. So they have a more chance of having bacterial tracheitis. So these are bacterial superinfection, and you see here, I cannot show you, this is the laryngoscopy, and there's a thick pus over the bottom. And there's the ulceration pseudomembranous, and usually the subglottic tissue is normal. So these kids were improving. They had a croup, they were doing well, and then suddenly they are horrible. They have a high fever, they are drooling, they look toxic, they are bad. So think about bacterial tracheitis. Okay, discharge criteria, of course, that they shouldn't have any stridor at rest. So we give 1 dose of racemic epi, we watch them for 2 hours. At the end, they should have all of these criteria to be able to go. If between, let's say within 2 hours or at the end, they have a stridor, they still have a stridor, we do try another one. And we keep them another 2 hours. If you cannot, you can admit. If you are nervous, you can admit those children. So there should be no stridor, their pulse ox should be normal, they should have a good air exchange, normal color, normal level of consciousness, and they can take by mouth, and the caregiver is understanding. So I have a case, this is a typical one of the croup. It's a 16-month-old, woke up at 2 a.m. with a barky cough, noisy breathing, and voice is hoarse. Had 2 days of a fever and runny nose. Vital signs, the fever is 102.6, respiratory rate is 60, pulse ox is 95. On physical exam, she has a stridor at rest. She has some subcostal retraction. What would be the immediate treatment, and what would you do on any lab or x-rays? What's the treatment? Dexamethasone and racemic epi. Right away. Let's see, this is my patient at Skyridge. And I have a website that can go, and you can click on it. I cannot click on. Okay. You see that kid is retracting all the way through, and that's the pulse ox that's beating. And she's nervous, she's looking around, and she has a stridor. I don't know that you noticed. And the stridor was biphasic. This one, so it's worse. Yes, if you have... This is worse than just inspired. Okay, so we had the treatment. So dexamethasone was the one, and we gave her racemic epi to this one. We tried to keep her comfortable. She was sitting in mother's lap. Did you notice that? Yes, sir.
You were talking about they know that people have a little bit about what are reasons for that.
Repeat. No, repeat of the stridor. They can have it, they can continue with the symptoms. Respiratory distress, hypoxemia, they are lethargic, they are not feeding well, so they come back, and we see a lot of them. One of the recent one that I saw, and I was very amazed that how children sent a 3-month-old home, that their own protocol is 6 months. And it was day one. That's the problem. If you have a day one kid with a problem, that would be... Yes, the progress, yes. One of the biggest one is how long is the symptoms. If you have a child that was fine going to bed, woke up so horrible, that one, the chance of coming back is higher. I myself give them another dose of dexamethasone at home because their worst night, everybody's worst night, is the 3rd night. It's not the 1st night.
Do you space it out like 3 days?
I don't. I usually say give it if they have a stridor at rest. or bulky cough, and it's at least 24 hours. Now, the dexamethasone will be effective within 1 to 2 hours. Best effect is 8, lasts up to 36 hours. And then the thing is up to. Some people are eating it faster. So usually it lasts to 24 hours. Okay, so we did, and this is after, and this is the same kit. After 2 racemic epi, a little bit, but you see that she's not retracting anymore. Her pulse ox is 100%. She's playing. She's happy. So I'm okay to send her home. You see how good she looks? I should have asked her to wave to me. I didn't. You see? Okay. It can go. Okay, so yes. Differentiation of an airway sound, and I don't know that you're going to get it if they can send you all of the slides. You can click on that one and you will have all of the noises. There's a lot of noises there. There's a wheezing and ronchi and crackles. Everyone is there. So stridor is a high pitch, is inspiratory. Yes. Wheezing is expiratory, so you listen to the patient and it's. And usually you need a stethoscope for wheezing. For stridor, you don't need it. And the other one is stertor, is snoring. After I treat the Croups, most of them will snore. They are comfortable and they sleep, and parents will think that's still stridor. Just go ahead and give them a reassurance that this is not. Okay, somebody asked me to do a high flow, so I'm going to talk about it. I'm not an expert on high flow. This is new for me as well. So high flow is also referred to heated, humidified, high flow nasal cannula, and it's adjustable mixture of heated and humidified air and oxygen at rates that exceeds the normal spontaneous inspiratory flow. There is no single definition, and you can give between 2 to 70 liters per minute of a high flow. And right now we are doing more and more of a high flow. It's easy to apply and it's tolerated. And originally it was only in the ICU, but right now we are using it in the pediatric floor and in emergency room. What's the indication for high flow? Respiratory distress, asthma, tracheomalacia, if it's very bad, if they are retracting and they need a surgery, this is not for every tracheomalacia. If you want to pre-oxygenate before the intubation, if they need more oxygen that you can give it by the bag and mask, you can put a high flow on them. I never used for that. And if they have a bronchospasm, it's better to give a humidified. High flow is with humidified than the dry oxygen. And you don't need to change them. You can just keep it on. And of course, if they have a hypoxic respiratory failure, contraindication, if they are hypercarbic respiratory failure, it would not exchange the thing, you need to intubate. Facial anomalies, excessive oral or nasal secretion, active vomiting, and bowel obstruction, of course, you're giving a high flow, it would be worse. And leak is the same as a bowel obstruction if there is a pneumothorax, pneumomediastinum, and if there's an agitation or confusion and they cannot tolerate it. So initial setting, the thing that I know, it's just this one. It has to be a temperature is 37. You start with 1 2 liter per kg up to maximum. I'm going to give you the maximum flow rate. And the FiO2 is between the room air to 100%, and you do not want 100% oxygen. So you dial it down. Yes, you keep it around 94 to 99%. So that's the high flow. This is the chart for it, that how much is the maximum for each age. Any question?
A lot of docs use 2 receiving enemies and
Yes.
then admit as a rule
Yes.
of thumb. Is that part of where you use age and ambulance risks?
I do consider the age of the patient. If they're less than 3 months, I absolutely admit them. Croup is a disease between 6 months to 6 years of age. If you are something besides that, be more careful. And we do, if they are the first day and they need more, they're going to get worse. So I am more with the duration of illness and age of the child. Any other one? I exceeded the 10 minutes, I'm so sorry. And Chris, thank you.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.